I remember someone saying to me, MS is a fascinating disease if you didn't have it. It is a fascinating disease, and whilst you often hear people say that MS is different for everyone, there are lots of commonalities as well. The big question for me is why did I get MS? There was no one in my family that had MS, and it was kind of outside of the realms of anything I would have ever expected to have got. I didn't know anyone in our family who had MS. No one. Like, I'd think back to grandparents and aunties, I didn't know anybody. So I kept saying to myself, was it genetic? Or was it something that I did that made me get MS?
Mostly it's actually random. People torture themselves by asking themselves, what did I do? You know, is it my fault? Is it my parents' fault? Is it an accident I had? But actually all of these things have been looked at, and the bottom line is we don't know. There are certain associations of MS. MS is much more common, for example, in Caucasian people. It's more common in women, probably 3 times as common in women than in men.
Like many illnesses, there are genes that make it more likely that you'll go on to develop MS. We know of about 100 genes which give you increased risk of developing MS.
So you have these genes that you're predisposed, but then there needs to be an environmental factor that is triggering the disease off. Also, we've known that now in Asian population, the incidence and prevalence is increasing, which has always been a country of low incidence and prevalence of MS. Asian colleagues do assume that it's the Western-style diet that is changing the prevalence picture of MS, even in Asia, not only here.
There are things within the environment that are also important. So low vitamin D is thought to play a role in the risk of developing MS, and many patients will have low vitamin D. The other important factor which probably primes the immune system to become reactive to the self is infection with a virus called Epstein Barr Virus, which is commonly the virus that causes glandular fever.
Most of us would be exposed to the Epstein Barr virus at some time in our life, usually in early childhood, when it doesn't cause glandular fever, it just causes a cold or a rash, and like lots of other things that little kids have, it's never really diagnosed. But if you get glandular fever, that is, you get the EBV as in adolescence, as that actual syndrome, it does increase the risk.
We know that smoking increases your risk. We know that obesity in adolescence increases the risk. So there's not a cause, but there's some combination of genetic and environmental factors which cause MS. There's nothing you could have done to prevent getting MS. There is evidence now that some of the increased risk of MS some of it comes from your genes, so you obviously couldn't prevent that, but also that effects that happen when you were a baby in utero. You could stop smoking. If you're a smoker, not smoking possibly would have helped. But these things are set in motion very early in our lives and then accumulate over time. And at this stage, apart from smoking, there's probably no really preventable risk factor for MS.
It is terrible for patients to think, I could have lived better and I wouldn't have got MS. Nothing could have been done to the genes that predispose you.
There's a very famous epidemiologist called Kenneth Rothman, and he thinks about the causes of disease as being like a pie. And to get the disease, you have to get a full pie. So one person, their pie might be mainly genetic risk, and they might have just that genetic risk, and all they need to do is perhaps be a smoker. The smoking segment might only be a little tiny segment of the pie, and all the rest is genetic. But once you put those things together, that person gets the disease because their pie is full. For many people, that pie will have multiple small segments. So there might be a genetic risk, there might be smoking, low sun exposure, glandular fever, a whole range of things. What Rothman says is that you can only get disease if you have the full pie. So you can have everything stacked against you, but if you don't smoke, even if it's a tiny sliver of the pie, you won't get MS. So I think the really useful thing of thinking about the pie like that is that you can take control.
In Australia in particular, we've shown that there's a thing called the latitudinal gradient. What that means is that the closer you are to the equator, the less likely you are to develop MS.
Interesting, though, is that recently this gradient is sort of diluted a bit. Yeah. So why is that? It is because we spend time inside, more and more inside. Even countries like Australia, like the beach culture here in Newcastle, where there's lots of sun outside. When we go outside, we protect ourselves with sunscreen, with hats. So we don't receive as much UV light as we're supposed to. And we know that sunlight is having an immense impact on our immune system through the skin. We don't know yet if vitamin D is just an epiphenomenon because you produce more vitamin D when you're out in the sun, or is it the vitamin D itself? So we're currently doing a study to see if giving vitamin D actually does change the outcome.
And so we have 2 studies going in Australia at the moment. One's called the PREVANS trial, which is looking at vitamin D supplementation for people at very high risk of MS to see whether we can stop them developing MS. And the other is the FOCIS trial, which is looking at giving them phototherapy, so essentially giving them artificial sunlight in that same group of high-risk people to see whether we can stop them developing MS.
There's loads of misinformation about MS, and it can be very confusing. So we want to bust some of the myths that are out there. Myth: I have MS, therefore my kids will get MS. Or, my parent has MS, so therefore I will get MS. This is false. While MS does have a genetic component, it's only one part. So let's talk about the stats. If you have an identical twin with MS, you only have a 1 in 5 chance of developing the disease yourself. If you have a parent with MS, you only have a 1 in 100 chance of developing the disease itself. And if you have MS and are worried about having children, they only have a 1 in 100 chance of developing MS. The majority of people with a relative with MS don't develop the disease themselves.
The important thing is that there are things that you can do to decrease that risk. So encourage them not to be smokers. Make sure they get a little bit of sun most days of the week. Not so much that they get sunburnt, but a little bit of sun. Get them to have a healthy diet as much as you can control it, not being obese during their early years and during their teenage years. Those are just the normal things that you would do as a parent. So, beyond those sorts of things of getting them to have healthy, active lives, they are at only minimally increased risk compared to the general population.
It's very rare that MS will be diagnosed right from the beginning. So the true definition of MS is that you have to have more than one attack that's separated by time, and also that there are lesions or relapse that are separated in different parts of the brain. So the MRI scan right at the beginning might show that you've got current lesions and that you've also had previous lesions, and that would mean a diagnosis of MS. If you've only got current lesions in your scan and there's no history at all of any other symptoms or episodes in your past that might give a hint that MS was there, then you'll be diagnosed with something that's described as clinically isolated syndrome. So that's just one attack with no evidence of any other lesions.
You're going to hear lots about relapses, and relapses are what the new medications are minimising. You probably had a relapse, which is what led to your diagnosis, which is kind of what happened for me with my optic neuritis. And I remember at the time thinking, oh my gosh, how many times am I going to have to, how many times am I going to relapse in a year? How regularly am I going to relapse? And then my MS nurse told me something that was really important. She said that neurologists don't tolerate relapses anymore. And in fact, when I look at all the people that have been in this video, only one had experienced a relapse since their diagnosis, and some of them have had the disease over 8 or 9 years. So relapses, from my understanding, are becoming less and less common because of the medications that we have today.
So most relapses don't have a cause that we can identify. About a quarter of them are associated with infections. They happen after an infection like a cold or a gastro or bladder infection.
So generally speaking, relapses have a certain time progression, and I like to tell the patients I see with MS that it will always begin with symptoms that get worse over hours to maybe days, and then it will stay the same for a few days or a few weeks, and then generally speaking it recovers over weeks to months. And that time progression, particularly at the beginning, when you're wondering whether or not a new symptom might be a relapse or not, is really useful to think about. So it should steadily get worse over time in the initial phases, and that's a good way of working out whether it's a relapse or not.
Patients do present with more fatigue and new neurological symptoms or worsening of their pre-existing symptoms that last, per definition, more than 48 hours. So if something only is getting worse for a few hours, then it's more likely that your body temperature is up with an infection or with exercise and heat. Yeah. So when you can cool down and it goes away, then that wasn't a relapse. A relapse is usually coming on over 1 or 2 days and then stay with you for a week or 2 or 4 weeks.
I would say if you have a symptom that is subtle and you're not sure, maybe it's only lasting a few hours and not that couple of days that we generally would consider a new relapse, maybe just sit on it for a day or a half a day and see if it gets better or if it gets worse. And if it's persistent, if it comes back, then it's time to give us a call.
So it's quite difficult for patients to recognize what is a relapse and what isn't, and even doctors often struggle. New occurring symptoms are quite easy to determine to be a relapse. As I said, there's often fatigue associated. People feel like a bus has been driven over them.
Visual changes or eye pain, tingling numbness, pins and needles in the arms or legs, double vision, slurred speech. This will typically recover, usually completely or almost completely, but the symptoms kind of depend on where the lesion actually is in the brain or spine.
MS is really variable, and it is quite hard to predict right from the beginning how bad or how mild someone's MS might be. Research is helping us to get better at doing this, and also the treatments that we have available for MS now are really good at reducing the number of relapses and reducing the severity of relapses. So, and research is going to help us get better all the time at predicting MS and helping people to decide on the right treatment right from the beginning. We know that not all lesions show up as symptoms or as a relapse, but those lesions do mean that something is happening in the brain, that your MS is active. So it's really important to go for your regular MRI scans to check what's happening with lesions and to visit your doctor regularly. Even if you feel well, those lesions are part of your MS, and it might mean that your medication needs to be adjusted.
After I'd had my first relapse, I was waiting for the next one. So that was the joy of going, when am I going to have the next one? And any symptom, I would be worried, is this going to be the beginning of a new relapse? And at one point I got really quite severe vertigo. And I remember getting up in the morning and walking around, seeing the walls climbing, thinking, oh my gosh, this is another relapse. And I called my MS nurse and I said to her, I'm having problems with vertigo. She asked me some questions and then she put me in touch with my neurologist. When I went in and saw her, the vertigo had nothing to do with my MS. It was something completely different, of which my neuro fixed pretty much on the spot. And that's kind of what you've got to really think about when you start to get symptoms, is they may not all be MS. So it's really important to have a process and a plan for thinking through those moments when you're worried you're going to have a relapse.
So the thought of a relapse can be very scary, and it's very energy consuming to be fearful of something which is a what if, and that can be hard to deal with. So a really good way to handle it or prep yourself is just kind of have an action plan there for what you're going to do in case something comes up, so you don't panic, it's not stressful, and you know exactly what to do when that happens.
My plan is a little different depending on whether I'm travelling and away or whether I'm at home. If I'm at home, I try to get onto my MS nurse straight away. If I'm travelling, again, I calm down. I get somewhere where I can stay for a couple of days and stay comfortably and know that I've got some medical help close by if I need to, but often I can just ride it out at home.
What I'd recommend you do is something like a fire plan. So in the media a lot you see in summertime the advertisements for planning for fire. So you know where all your photographs are, you know what you're going to do if a fire comes towards your home. The same thing with MS. So what you would do is you have a plan. Who are you going to call? What are you going to do? But then you box that away, that idea. You might want to write it down, but you put that away so that you can get on with living. And sometime down the track, you may have another relapse, but we don't know if that's a day, a year, 10 years from now. So what you'd want to do is not live looking for new symptoms, it's just live. And then if you have new symptoms, then you can go to that plan and follow it. The best thing for you to do is to contact your MS provider, and if you come through an MS service, the nurse's role is to help you work out what you're experiencing, if it is something that needs to be looked at by a neurologist, if it's something we can just sit on and see what happens to, or if it's not MS related at all. So get in touch with someone. So if you think you're experiencing a new relapse, don't worry about it, don't panic. Give your MS care provider a call. There will be road bumps in this journey of MS, and what you're experiencing may not be a relapse, and if it is, we can deal with it. What is a relapse and what isn't a relapse is a really good point of discussion. I wouldn't say to anybody newly diagnosed that you have to work out what is and what isn't an attack or a relapse at the time. I think your role is to ring up and present those symptoms to us, because like I said, it's different for everybody. And a new relapse can present itself like very similar to a previous relapse, but worse. Or it can be a very subtle symptom that you're not sure whether it might be a patch of numbness or something. It might not be very obvious what it is. So when in doubt, call your MS care provider. Our job is to answer your call and work out whether you're having new disease or not. A true new MS relapse is a new neurological symptom that lasts for at least a day or two, fairly persistently, and there's no other reason for it, no other disease or infection or particular stressor causing those symptoms. It also needs to be a month away from a previous relapse. So if you can tick those things off and you can ring up your MS care provider or the MS clinic if you attend a clinic and give them that information about when it started, what it's like, what the intensity is like, and then we go from there and work out whether it is something that needs to be looked at straight away or if it's something that's not an MS attack. What we do say is that eventually you will have a much better idea of what's going on with the disease than we will have. Right now, when you're newly diagnosed, that's our job to help you work out what's what. Eventually you can call us and you'll say, I think I'm having a relapse, this is what's going on, and we can sort it out. And usually we don't hear very often from people then because they've got it worked out. And MS becomes a part of them, not they're all about MS.
So my plan is this. If I get a new symptom, I kind of sit on it if it's not bothering me, and I look to see what it does over 24 hours. Most of the time, I go to bed and the symptom goes away. You'll find with MS, when you're tired, some of your symptoms will come up again. You go to bed, you wake up and that symptom's gone. So in most cases, that's what happens with me. My neurologist doesn't have an MS nurse in her clinic anymore. So my plan is if it's during business hours, I would call the receptionist at my neurologist and say, I think I'm having a relapse. If it happens over a weekend, I would actually go to the hospital where my neurologist practices and to be admitted. But I'd only go to the hospital if the symptom I had was really worrying me. And for me, that's pain, balance, or weakness. Those three things, if I had any of those three things and it was a weekend, I'd probably consider going to the hospital. But outside of that, tingling, I just sit and wait on it. So that's my plan, but honestly, I've never had to use it. I haven't had a relapse post my first initial relapse. But knowing I have a plan gives me a sense of control that if I'm in that situation where it's really scary, I know what to do, my husband knows what to do, we just go.